Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
It's good to have you. Thank you so much for giving us your Sunday at a very short notice.
Oh, of course. Of course. It's a pleasure.
All right. Okay, I'm just going to go ahead here. Dr. Jackson, Gabrielle Jackson is originally from Chicago, Illinois. She obtained a bachelor's in biology from Bradley University. She also earned a Doctor of Dental Surgery degree in 2012, followed by a master's in Oral Biology and Prosthodontics from the University of North Carolina School of Dentistry in Chapel Hill. The blue, Carolina blue, that's Tar Heel. That's the Tar Heel country out there. I did a master's in public health from Carolina, so I really, it's good to see someone from there. Anyway, she did serve as a chief resident while she was there. She also served as a team member, and an ADA award recipient for the UNC Malawi Project, where she was able to raise funds for a mission trip to Malawi to provide free care to more than 500 people. Dr. Jackson was an Albert Schweitzer Fellow and is a published researcher and lecturer on the subject of implant prosthodontics and digital technology. She's a member of the American College of Prosthodontics, the International Congress of Oral Implantologists, and the Academy of Osseointegration. She currently works in private practice in Dallas, Texas. Welcome to Dental Webinar Series, Dr. Jackson. Please.
Thank you so much for having me. Let me go ahead and get this screen share going. I hope everyone's doing well on this beautiful Sunday morning. Right. All right, how does that look?
Yeah, it looks good.
Good. All right, so yes, again, good morning. First off, thank you so much for having me. I do recognize that we have a wide range of practitioners here, some still in training, others who have had more practice experience. This is going to be a really casual conversation, so please feel free to ask any questions. I'm open to all questions, so ask away during my presentation. I do first want to just say that I don't have any financial relationships related to anything I'll be showing to you guys today. So let's go ahead and jump right into it. All right, so we're talking about anterior implants and specifically immediate loading. Right now, we're living in times where patients' expectations are continuing to increase in terms of comfort, aesthetics, and shorter overall treatment time. So the purpose of this review is to explore the concept of immediate loading of anterior implants and also cover all the indications for clinical practice. All of the critical aspects that could influence these outcomes, we're going to consider. Of course, we have, patient selection based on bone quality and quantity, the implant number or design in the anterior space. Of course, primary stability, occlusal loading, all of these things we're going to consider during this talk. So before we dive in, the first thing we have to think about, again, is case selection, and that goes hand in hand with treatment planning. And so when can we immediate load? This goes hand in hand in the way that we treatment plan the case, of course, like I said, and throughout the course of this presentation, we'll be starting from the very beginning with implant diagnosis, going into surgical planning, and then into the restorative phase. I'll also include, excuse me, some digital versus conventional approaches we'll discuss. And so first question we want to ask is, are we starting with a draft pick, or is this a case maybe from the injured reserve list? We can look at this several different ways. Are we starting with an existing natural tooth that has yet to be extracted? We want to replace that with an implant. Are we missing teeth already? Or is the implant already placed? And are we looking just to restore this? And in that case, we're not talking about immediate load, but just in general for anterior implants, these are things we want to think about. And why is this important? Specifically, it's important for informed consent. We have to be able to communicate with our patients. Are they going to have black triangles? Might they have, restorative margins that are visible? Are we going to shorten the crown if we immediate load? And might they have a flipper, or should we decide to two-stage? The patient needs to know this from the very beginning. So we're going to start here with one patient case. We'll walk through this case, and then I have some additional cases for us to talk about at the end. So this is Mr. Odin. He's a 35-year-old Taekwondo instructor. He was admitted to the dental school with the chief complaint of needing a routine checkup, as he hadn't been to the dentist in a while. And so amongst other restorative needs, there was the problem with tooth number 9, okay? When he got to the graduate clinic, he had already had that tooth removed. And at that point, I decided to move forward with our radiographic assessment and determine that he had sufficient bone quality and quantity to go ahead and proceed with implant planning in that site. And so with regard to our implant planning, the diagnosis portion is the most important because it's going to lead us all the way. And with that, we have both the restorative component and surgical component of diagnosis. So first, we'll look at restorative space. So the most important first step in our diagnosis, in my opinion, is assessing restorative space. And in terms of vertical dimension, specifically for anterior teeth, we know that we need about 3 to 4 millimeters for our abutment height, 5 to 6 millimeters for the crown, giving us a minimal total restorative space of 8 to 10 millimeters. I think this is a step that's often missed. And like I said, it's the most important. So if we don't have the space for the tooth, then we shouldn't be placing an implant. There's different ways to assess this, right? Clinically, we can assess it. We can take a perio probe. We have diagnostic casts we can make measures on. We can also take our radiographic information, use some software to make measurements that way as well. And so, again, clinical exam, we can look at our casts. Digitally, we can either do an intraoral impression and scan that, make some measurements, or we can scan our actual diagnostic cast with lab scanner. So that's a cool way to look at things. And I really think it's imperative, especially not only that we can measure the space, but the cool thing with the digital is that we can assess the emergence profile, the patient's occlusion, and our ability to immediate load with a screw retained provisional. So we can see here on the right how it'd be possible to design a crown with an occlusal access that is not coincident with our MI contact point, right? And that's an ideal situation. We can plan for that in the very beginning and communicate that with our patient. As far as occlusion, we know that we want mutually protected occlusal scheme, right? And so that's when MI coincides with the optimal condylar position or centric relation, or in essence, when our anterior teeth protect our posterior teeth and vice versa. So in this situation, in protrusive, we see that the patient is guiding on his canine and also on tooth number 10, both canines and tooth number 10. So this is going to provide an ideal occlusal scheme for us to go ahead and fabricate an immediate crown, slightly shortened so it's completely out of occlusion and within these functional movements. That's going to allow for the best healing and integration of the implant. Moving along to gingival margin position and implant position, which are both very closely related. And as you can see here on the left, with regards to our patient, Mr. Odin, we have the most ideal situation where the adjacent gingival margin is much higher than the site that we plan for our implant, right? That gives us a lot of room to be able to sculpt that tissue and that do plan gingival margin to where it should be. There are cases where we are equigingival, right, in terms of sites. And on the right, this is a more unfavorable situation where the site for the implant location at number 8 is much higher already than the adjacent tooth. Okay, and so these are important things to consider. When the gingival margin is not in an ideal location, you can consider and should consider some soft tissue grafting, some hard tissue grafting, whatever you might have to do to create a more favorable situation, if possible. And with regards to implant position, so, we all know how critical the position of the implant is, especially in the aesthetic zone. And so based on that ideal tooth location, with respect to the gingival margin, as we just reviewed, we can then merge that information with our CBCT data. Also take into consideration other clinical data. We always like to use this crown-down approach in diagnosis and treatment planning because it's crucial for our surgical success. And so, of course, we can conventionally wax up our tooth here. We can scan it and convert that into a digital wax up. Or what's really cool, and another cool option that digital world has brought to us, is the ability to actually mirror the contour of the adjacent tooth. And that's if the gingival margin is at the ideal location. It's a super easy and clean way to do things. There are some biological principles we must follow. And so in order to determine the ideal implant placement, we need to establish the proper emergence profile. We know that the implant has to be 3 millimeters from the gingival margin and 2 millimeters from the buccal plate. There are some other rules that we need to follow as well. That being, if we have a situation where we want to place an implant next to an existing implant, basically we know that we can get an average of 3.4 millimeters of papilla height. If we're talking placing an implant next to a tooth, the maximum we'll be able to achieve is 4 millimeters. So say, for instance, if the patient already has a very long contact point of 5 millimeters, we know that there's more than likely going to be a very small black triangle. And again, we can communicate with that patient beforehand, especially if they're high risk, especially. And again, there's a reason we're dealing with tenths of millimeters, and it's because it's important. It just makes it even more important to consider adjacent teeth and implants when discussing with your patients. Other biological rules, we need to properly diagnose adjacent teeth for endo, perio, because we don't want to be put in this position either. This happens commonly. Moving on to periodontal biotype. So we know that periodontal biotype influences the therapeutic outcomes of implant dentistry within the aesthetic zone. And when we treatment plan for these types of implants, we know that a thin periodontal biotype may involve the need for additional hard or soft tissue augmentation prior to implant placement, and conversely, where a thick or average biotype may lead to more predictable outcome when placing an immediate dental implant. And that's because the thicker labial plate may be less likely to resorb during healing. It's an easy way to assess this is on clinical exam. Can you see the probe? Yes or no? And another cool option with the digital side is that we can get a pretty nice estimation via superimposition of the cast and the CBCT, right? We can see here that at the most coronal position, it looks like the tissue could be about 2.5 millimeters thick, which is coincident with the patient's thick type, biotype that we can assess clinically as well. Other things we want to think about is a gingival scallop, right? A flat architecture is going to lead to an increased aesthetic prognosis compared to one that is scalloped, which is what we have in this case. And again, papilla height, which I mentioned, is also going to be a factor to consider. Moving on to our surgical planning. And so we know that with the surgery, we can do it non-guided or use a conventionally generated guide, or we can do it partially or fully guided with something that we make via CAD/CAM. Okay. As far as our implant placement approach, we can either do an immediate placement, which is the same time as the tooth is extracted carefully, or we can do our two-stage approach after our initial healing. Immediate placement and loading is an option for both situations here. And I just want to show you guys how important it is to pay attention to the nuances here. So in this situation, the patient presented, like I said, with a tooth already removed. We have a flipper in place. And if you notice how small that tooth number 9 is and how short it is relative to where we want that true gingival margin to be. Now, the patient had already had the CBCT performed when he came to me, and as you can see, the radiographic marker was put on the face of that flipper tooth. Now, if I hadn't paid attention or had photos or seen the patient, it'd be very easy for someone to base the implant position on this radiographic marker here. And you can see if that was the case, the implant would have been placed too shallow, right? Which will lead to a very poor outcome. So this, again, is just showing you to pay attention to the details, to the nuances, so you don't miss important and very crucial steps like this. All right, moving on to our surgical protocol here. So the difficult component in guided surgery is our soft tissue management, and there are many different flap designs you can choose to do, but however you want to make sure that the design allows you to preserve an adequate amount of soft tissue. And so we elevated a small flap towards the lingual here to maximize our keratinized tissue. Whenever using a guide, I always make sure to check and make sure that the guide is seated adequately. I think a lot of people don't realize that small, misfits can result, especially in this area, in major drawbacks in terms of your outcome. So, we say you're only as good as your guide. We definitely left a large amount of tissue here, you can see, because again, you want to maximize what you have to work with. And that's always just a better situation than the latter, okay? And so this is the patient same day. Immediate loading, has shortened the transitional period between the implant placement and the restoration considerably. It benefits the patient and benefits the patients, which include reduced overall treatment time, reduced number of visits to the clinician. It also helps in patient comfort during the healing period and leads to improved aesthetics and phonetic outcomes as well. And some benefits to guided surgery in general, a few of them I just mentioned: more precision and confidence, reduced surgical time, reduced complications. You're able to avoid bone augmentation when the implant is placed the right time, or the first time, in the right place. And it also helps, again, with facilitating immediate provisionalization, because we know in the very beginning whether we can do it or not. So again, an important thing is you want to determine your ideal gingival margin position. You want to consider and diagnose your biotype, gingival form. You want to determine the aesthetic risk or demand of the patient. And most importantly, is the implant stable when it's placed? And what is occlusion like? Okay. Now we're going to move on to our provisional phase. So our provisional implant restorations are often the most challenging part of implant dentistry. And the point of this is to create the emergence profile that appears natural and is in harmony with the surrounding tissue. We want to mimic, the existing dentition contours. And so there are 3 different areas that we tend to focus on with the provisional, the most important being the subgingival emergence profile. And a cross-section of the CBCT will identify the adjacent subgingival contours as either being triangular, round, or ovoid. And this is really important because it allows your provisional to communicate the soft tissue and tooth contours to both your lab techs, but also to your patient. Your patient might say, well, you know what, I think gingival margin needs to be a little bit higher here, until they're happy with things to go ahead and move on to your final restoration. Here, I just wanted to take a moment to show commonly what we see, what happens. So this patient here has a very scalloped gingival architecture. We can see that, but oftentimes what happens is, again, if the implant is not placed deep enough, or if it's placed too facial, or if it's placed too facial, this is what we get abutment margin, right, and a very short, stumpy looking crown relative to the lateral architecture that the patient has. And so that's why it's really important to pay attention to these small numbers and when you're planning and knowing the rules. Now we get to contouring our soft tissue. So provisional restorations, initially you want to make sure you under contour them at the gingival margin from the mesial to the distal line angles, okay? Then you want to go ahead and gradually add in increments of 0.5 millimeter to 1 millimeter. Adding to your facial is going to help with the apical migration of your gingival margin, where adding, to an interproximals will help to support the tissue to bring it down further, right? If that's what you're trying to do. But again, you always want to remember the biotype, okay? Thicker biotypes can withstand a little bit more pressure, a little more resilient than the thin biotypes. And of course, you want to remember with blanching, should limit that to 10 to 15 minutes. The patient should never leave your chair with the tissue still blanching, okay? And so this is what we have over time. The first photo you can see here was the same day of the procedure. Then we have a week later, and we have 2 weeks. That's about a month. Then we're at 6 weeks and 8 weeks, okay? And we just took our time to, in a controlled way, to push the tissue up to where we wanted to. Of course, we could have started maybe with a little less tissue in the very beginning, but again, it's always better to have an abundance than to have too little, okay? And so we get to a place where our soft tissue is healthy, we have papillar fill, there's gingival symmetry, and then we're now able to move on to the final restoration phase. So ideally, we've set ourselves up for the best aesthetic final result through our provisional. And now all we have to do is accurately communicate that with our lab tech by way of our impression and maybe some adjunctive photos. So we can do the conventional method, which is with a custom impression coping, as we see here on the left, or digitally, there's a couple ways we can do it. We can do a scan body impression. We can capture that soft tissue before removing the provisional, or we can remove the provisional, put our scan body in place, and then capture the tissue, okay? What we know is that the research tells us that patients prefer digital impressions. That's widespread. So it may be something you want to try to incorporate if you're not doing that already. So from here, we're moving on to the design of our final restoration. We get our core file, we have our custom abutment. Sometimes people choose to fabricate their custom abutment at the time of provisionalization, right? Which is fine. If not, they wait until this phase, and we can also design our final crown. And so, again, the most important part, you get to the end, is lab communication. I worked with Lee Cope on this case, and it did take a few tries. I want to say at least 3 times to get our final result. But again, that's where communication comes in. Photos, knowing your patient's aesthetic demands and kind of what they're wanting in the very beginning helps to make this all go very well. Okay, so now we have another case here, single implant anterior canine here, where we see a significant defect. So this is a case where we know we need to do some augmentation prior to implant placement. And so we decided to go ahead and move on with grafting. In this case, the defect was exposed, the graft was placed, and we 2-stage it, of course. So after grafting, you can see we gained a significant volume, come back, place the implant, and in this case, we decided to go ahead and let it heal in 2 stages. Okay, we did not immediate load, but you can see here how we were able to get a nice outcome. And so that's where really taking the time to see, what might be best given the situation, right? This is a canine, this is gonna be a guidance tooth. So of course, this wouldn't be a good idea to go ahead and immediate load this particular site, especially given the fact that it was grafted prior to, and all these things we need to just be thinking about. There's other cases like this case where patient may need multiple anterior implants. This patient needed implants in site 6, 10, but also 23 to 26, 27, 28. And so what we decided to do is go ahead and immediately load implant 6 and 10. And we provided the patient with a flipper or an interim removable prosthesis on the lower, while the upper healed and the lower healed as well. And this resulted in a really good final outcome for the patient. Sometimes we just have to work with what we have. This patient presented from perio with implants already placed. You can see there's a really large defect, very minimal tissue. I understood that the patient had at least maybe a couple of rounds of bone grafting prior to. And you know, sometimes you just have to do the best with the situations you have, and then it doesn't mean that you will have always a compromised outcome. A lot of times the patients will be happy. Here are a couple more examples. So on the left, again, this is a patient who presented to me for final restoration after the surgical specialist placed the implant. I believe they used the flipper to make the immediate, but you can see how facial that implant position is and how, you know, not favorable this whole setup is. And so, of course, when the patient came to me, this implant was not in good shape. It actually needed to be removed, and we had to start over from scratch. And so that's why it's really important to work together as a team, not only, you know, for you to work with your surgical specialist, but for your specialists to really take the time to get aligned with you, so that way you can have the best outcome for your patients. The second case here in the middle was another case where the implant, again, was already placed. You can see it's far too facial. However, the saving grace in this situation is that the patient has a low smile line, and we were able to make the best of the situation we had in terms of the final outcome. The case on the very right, another similar situation. There's an implant placed at number 6, far too facial. We had tooth number 8 and 9 that needed to go, and so we planned to replace that whole anterior segment. We used some pink porcelain, and again, the patient has a low smile line, so they're very happy. And so the point is that, you know, even if we don't start out with the most ideal situation, we can still make an improvement, leaving the patient in a better place than they were when they came. And they are often very happy with the outcomes when things are communicated clearly. And so again, this is just a reminder to partner with your surgical specialists. We're not magicians, but the more we work together to get aligned and communicate, you know, as best we can with our patients, we can deliver amazing treatment, okay? All right, so in closing, you know, you want to remember to diagnose appropriately, remember your biological principles, you have to follow those, communicate your patient expectations, know when to work with your specialists versus, you know, attempting to do it all by yourself, and incorporate digital technology where you can. In terms of our maximizing our aesthetic outcomes and when immediate load implants might be most indicated is when you have a patient with a thick biotype, when there's minimal trauma in your tooth extraction technique, when you have primary stability, when your occlusal scheme is set up to support that, and also when you have favorable biological factors within the patient. Contraindications, of course, are going to be when you have heavy occlusal contacts with opposing dentition, when you've lost the buccal plate in a traumatic extraction, when you have the presence of other disease, periodontal disease and other diseases, and when you also have insufficient soft tissue coverage. That's when you want to consider two-staging your approach, okay? And that's about it. So I know it's pretty short and straight to the point. I'm so grateful to have had this opportunity to share with you all today. And I'm open to any questions.
All right. Thank you so much, Dr. Jackson. We do have a question here. It said, if you temporize an immediate load case with a screw retained implant crown, why do you use cement retained for the definitive crown?
So I'm not sure that I understand, but usually if you screw retain in the very beginning, you want to set up your provisional in the way that you want your final restoration to be. So if you're planning to cement retain your final restoration, you would usually do that in your provisional as well.
Okay.
And it's usually because you can't screw retain.
Yeah.
That's but you know, you brought up a good idea though, because I think sometimes we don't consider cement retaining in cases that we should sometimes. So for example, if you have a really high aesthetic patient, high aesthetically demanding patient, and you know that from the very beginning, sometimes when you're constantly removing your temporary to try in a new final crown, that's really disturbing the tissue, right? Your gingival connection tissue, which can lead to resorption. So sometimes it's better to actually have a final abutment in place and only remove the coronal crown portion if you're gonna, you're expecting to have a lot of try-ins to minimize that tissue trauma that can lead to loss of your papilla and such.
All right. Thank you so much. Dr. Gordon, are you there? Dr. Brandon Gordon, can you hear me?
Yes, I can hear you.
You are able to, yes, you're able to speak. I want to just give some comments here. I know you have been, I just saw you and I'm like, let me pick on you. I know you're coming up, you're going to be talking about provisional restorations sometime soon. Do you have any comments?
Not really. The only comment I had really was with the reference to that last question, whether you go like a screw retain. I usually use a lot of screw retain provisionals too, because I know that I'm going to be taking that on and off multiple times. And it's just easier to maintain if I need to add a little bit of composite or whatever material I'm using on the facial or interproximal, whatever, to kind of shape the tissue a little bit more. It makes it easier because if you using a cement retain, there's always that chance of leaving some, temporary cement behind, even though if you clean extremely well, it's still that opportunity to leave something behind, which can cause some further gingival irritation down the road or even implant failure. So that's neither here nor there, but at the end of the day, I don't have much more to add at this point.
All right. All right. Thank you. No, sorry. I just had to pick on you. You are, you are my favorite go-to person. Anyway, Dr. Jackson, it's been wonderful having you here. You've got to come back. I'm sure I'll give you another long time to prepare. I mean, whatever you want to. So we are trying to see how we can. So in Nigeria, so the object here is that in most schools, implant curriculum does not include a laboratory component. So my goal is to be able to get the theory or the didactics all squared out so that we can proceed to having some laboratory exercises, maybe fabricating a surgical guide by the students. So it becomes like something that we have and placing of implants even with pig jaws or on the cast or with different types of wood or something. We're trying to develop something here, and these lectures have they kind of helped us to put the students together, and hopefully, so I will be picking on you, calling on you, later on to see how best we can transit from just talking about it to having something that we can demonstrate right here and having them to have all the things that they need to be able to do it. So I'll be calling on you. Thank you so much. This is really, really, really very, very, very good presentation.
Thank you.
Another question here. What methods do you employ in pushing back and contouring the gingiva during the period you're using the provisional?
So again, just small increments of composite additions to the cervical and possibly interproximal. And I just wait at least about 2 weeks in between each time I add the increments to bring the patient back to reevaluate. Okay.
I know in an earlier presentation, a speaker did talk of, especially when if you did the extraction, if the tooth was there before, with scanning and the CBCT, you can actually scan and have what was there before. and make a provisional that is exactly like the tooth, such that that really helps. Anyway, if you have any more questions, please send it in. During the week, Doctor, are you able to give us the post-test questions later on? Okay. I mean, this is going to help so that we can retain the material. This is going to be available on YouTube, so you can go back and listen to it. There's a lot of information, especially if you've not done it before. It's a lot of information, and that's why we want to use this and add some laboratory components to it, so that the students can get it, and even practitioners. And a lot of more than 60% of the people on the call today are dental practitioners in their own countries. Anyway, thank you so much. We're going to be available. We're going to be back on Friday with Dr. Elbrashi. Dr. Elbrashi, he works in Portland, Oregon. He'll be speaking on all on 4 concepts. We're looking forward to having him back, because he's been here and he's usually free on Fridays. So he's going to be here on the 17th. You don't want to miss it. You want to call, tell somebody about it, and let's all meet. Thank you so much. You guys have a wonderful Sunday.
Thanks.
All right.
Bye.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator